Hello dear students, today is our fourth lecture of radiotherapy. The subject of our today's lecture is Basics of Radiotherapy of Malignant Tumors. In today's lecture I will explain about lung cancer, larynx cancer, esophageal cancer, breast cancer, cervical and brain cancer radiotherapy. As you know, that radiotherapy is a cancer treatment that uses high dose of radiation to kill cancer cells and shrink tumors. Radiotherapy may be used in the early stage of cancer or after it has started to spread. It can be used to try to cure the cancer completely. In these cases we name it curative radiotherapy. Make as a treatment more effective, for example, it can be combined with chemotherapy and surgery. In these cases, we name it neoadjuvant radiotherapy. Reduce the risk of the cancer coming back after surgery as adjuvant therapy, and relieve signs of a cure it is not possible as palliative radiotherapy. Radiotherapy is generally considered the most effective cancer treatment after surgery, but how well it works varies from person to person. Any tumor could be controlled by radiation therapy if sufficient dose were delivered to all tumor cells. Although technological advances in physical treatment delivery have been developed to allow more radiation dose conformity, normal tissues are invariably included in any radiation field within the tumor volume and also as part of the exit and entrance dose relevant for the particle therapy. And you know that in all methods of radiotherapy, our main aim is maximal exposure of tumor area, tumor tissue, and maximal protection of surrounding normal tissue. First of all, I will explain about lung cancer radiotherapy. Lung cancer is one of the most common and serious types of cancer. There are usually no signs or symptoms in the early stages of lung cancer, but many people with the condition eventually develop signs including a persistent cough, coughing up blood, persistent breathlessness, unexplained tiredness and weight loss, and ache or pain when breathing or coughing. In this picture, you can see different types of lung cancer. Cancer that begins in the lungs is called primary lung cancer. Cancer that spreads to the lungs from another place in the body is known as secondary lung cancer. There are two main forms of primary lung cancer. These are classified by the type of cells in which the cancer starts growing. They are non-small cell lung cancer, as you can see here. This is the most common form, accounting for more than 17% of cases. It can be one of three types: squamous cell carcinoma, adenocarcinoma, or large cell carcinoma, and small cell lung cancer, a less common form that usually spreads faster than non-small cell lung cancer. Small cell lung cancer differs from non-small lung cancers in the following ways. Small cell lung cancer grows rapidly, spreads quickly, responds well to chemotherapy and radiotherapy, and small cell lung cancer is frequently associated with distinct paraneoplastic signs. For example, a collection of symptoms that result from substances produced by the tumor. There are different types of systems used to stage cancer, but the most common and useful staging system for most types of cancer is the TNM system. In the TNM system, The overall stage is determined after the cancer is assigned a letter or number to describe the tumor, T, mode, and metastasis in M categories. The T describes the original or primary tumor. N tells whether the cancer has spread to the nearby lymph nodes. And finally, M tells whether the cancer has spread to distant parts of the body. That's T, is tumor, N is nodes, and M, metastasis. The primary tumor, T. The T category can be assigned a letter or a number. For example, Tx means there is no information about the primary tumor can't be measured. T0, there is no evidence of a primary tumor. T in situ means that the cancer cells are only growing in the layer of the cells where they started without growing into deeper layers. This may also be called in situ cancer or precancer. A number after the T, 1, 2, 4, or 3, and 4 may describe the tumor size and amount of spread into nearby structures. The higher the number, the T number, the larger the tumor, and the more it has grown into nearby structures. In this picture, you can see means of T category. Okay. Next category is N, lymph nodes. Lymph nodes near the primary tumor are usually checked by a cancer has spread into them. Lymph nodes are small bean-shaped collections of immune cells, as you know. Many types of cancer often spread to nearby lymph nodes before they reach other parts of the body. The N can be assigned a letter or a number. NX means there is no information about the nearby lymph nodes, or they can't be assessed. N0 means nearby lymph nodes don't contain cancer. A number after that, such as N1, N2, and 3, may describe the size, location, and number of nearby lymph nodes affected by cancer. The higher N number, the greater the cancer spread to nearby lymph nodes, as you can see in this picture. And finally, the M category, metastasis, and the M category is assigned a number. M0 means that no distant cancer spread has been found, and M1 means that the cancer has been found to have spread to distant organs or tissues. Other factors that can affect a cancer stage, for example, grade. For most cancers, the grade is measure of how abnormal the cancer cells look under the microscope. This is also called differentiation. Grade can be important because cancers with more abnormal looking cells tend to grow and spread faster. The grade is usually assigned a number with lower numbers, for example G1, used for lower grade cancers. In low grade cancers, the cancer cell look fairly normal. In general, these cancers tend to grow slowly and often have a better outlook. In high grade cancers, the cancer cells look more abnormal. High grade cancers often tend to grow quickly, so they may need different treatments than low-grade cancers. One of other factors is cell type. cancers in some parts of the body can start in different types of cells. Because the type of cancer cell can affect treatment and outlook, it can be a factor in staging. For example, cancers of the esophagus are mainly either squamous cell cancers or adenocarcinomas. Squamous cell esophageal cancer are staged differently from other type of esophageal cancer. Tumor location. For some cancers, the main tumor's location affects outlook and is taken into account in staging. The stage of cancer of the esophagus, for example, depends on whether the cancer starts in the upper, middle, or lower third of the esophagus. And blood levels of tumor markers. For some cancers, the blood levels in certain substances can affect the stage of the cancer. For example, in prostate cancer, the level of prostate-specific antigen in the blood is taken into account in assigning a stage. Results of tests on the cancer cells. For some cancers, laboratory tests done once the cancer cells are an important part of staging. For example, in breast cancer, the stage can be affected by whether or not the cancer cells have proteins called hormone receptors on them. And finally, a person's age. For some types of cancer, for example, thyroid cancer, a person's age at the time of diagnosis can affect their outlook, so it is taken into account when assigning a stage. That's in oncology and in treatment of oncologic disease, we use from different types of different factors of cancer, such as T and M classification and cell type, tumor location, and other factors. Okay. In this picture, in this table, you can see T and M staging of non-small lung cancer, as you can see here. In T, for example, in T1 stage, size of tumor is less than 3 centimeter. In T2 stage, size of cancer is more than 3 centimeter, main bronchus, invades pleura, and 2 centimeter, more than 2 centimeter distal to carina. In T3 stage, invasion of chest wall, diaphragm, mediastinal pleura, and less than 2 centimeter from carina. And finally, in T4 stage, invasion of the mediastinum, great vessels, trachea, carina, and malignant effusion. And you can see N and M classification of lung cancer. Following a lung cancer diagnosis, staging determines the best options for treatment. Many factors are evaluated, including the size of the tumor and the extent of spread. For example, as you can see here, the cancer is small, no larger than 3 centimeter for stage first A, up to 5 centimeter for stage first B, and has not spread to the lymph nodes. And in final stage of cancer, the cancer has spread to form new tumors in other parts of the body, such as the bone, brain, liver, and adrenal gland. It is later stage of lung cancer. Okay. You know that for diagnosis of lung cancer, we can use from different types of diagnostic methods, such as chest X-ray, computer tomography, needle biopsy. For example, in this chest X-ray, you can see lung cancer with abnormal tissue, abnormal shadow in right perihilar region with incorrectly borders with heterogeneous intensity. Okay. In this picture you can see also chest X-ray and computer tomography of lung cancer. On computer tomography you can see different layers and you can correctly estimate the localization, borders, intensity, size of them. It's so important for providing of treatment. And lung biopsy. And lung biopsy is interventional procedure performed to diagnose lung pathology by obtaining a small piece of lung which is examined under a microscope. Beyond microscopic examination for cellular morphology and architecture, special stains and cultures can be performed on the tissue obtained. One of modern diagnostic imaging is PET scan of lung cancer. The use of PET scan in the workup and management of patients with lung cancer has greatly increased in recent decades. The ability to combine functional and anatomical information has equipped PET scan to look into various aspects of lung cancer, allowing more precise disease staging and providing useful data during the characterization of indeterminate pulmonary nodules. In addition, the accuracy of PET scan has been shown to be greater that of conventional modalities in some cases, making this method a reliable, non-invasive method for the investigation of lung cancer. However, the interpretation of PET scan findings presents different pitfalls and potential confounders. Therefore, it is imperative for pulmonologists and radiologists to familiarize themselves with the most relevant indications for and limitations of PET scan, and seeking to protect their patients from unnecessary radiation exposure in inappropriate treatment. That is, positron emission tomography is so important modern method for diagnosis of lung cancer. And other methods such as needle biopsy, bronchoscopy, and thoracoscopy also are used for diagnosis of lung cancer. For example, in needle biopsy, after a local anesthetic is given, the doctor uses a needle that is guided through the chest wall into a suspicious area with computer tomography or fluoroscopy to obtain a tissue sample. This type of biopsy may also be referred to as closed transthoracic or percutaneous biopsy. Okay, and bronchoscopy is the primary procedure for diagnosed lung cancer, and with this method also we can perform a biopsy. A skilled pathologist will then examine under a microscope the tissue sample, and after that doctor removes during the procedure in order to make a precise diagnosis. And thoracoscopy is a procedure in which we use to look at the space inside the chest, and this is done with thoracoscope, a thin flexible tube with a light and small video camera on the end. This tube is put in through a small cut made near the lower end of the shoulder blade between the ribs, and this method also is so important for diagnosis of lung cancer. Okay. In this picture, you can see a summary of treatment approach of small cell lung carcinoma. As you can see here, in early stage, in a limited stage, this good performance status of patient, we use combination of chemotherapy and radiotherapy. In extensive stage, we can use from different combinations of chemotherapy. In complete responders in all stages, prophylaxis cranial radiotherapy. Poor performance in all stages, modified dose combination of chemotherapy and palliative radiotherapy. That is providing of treatment options of treatment of lung cancers depend on stage of cancer. Non-small cell lung carcinoma is any type of epithelial lung cancer other than small cell lung carcinoma, and when possible they are primarily treated by surgical resection with curative intent, although chemotherapy has been used increasingly both pre-operatively as neoadjuvant chemotherapy and post-operatively as adjuvant chemotherapy. Role of radiotherapy for treatment of lung cancer. Moderately radiosensitive tumor, non-small cell lung cancer is moderately radiosensitive tumor. Dose escalation needed. Surrounded by organs which are dose limiting, heart, opposite lung, spinal cord, esophagus. That is, during providing of radiotherapy, we can protect surrounding organs. And respiratory motion, pertinent factor necessitating motion management in radiation delivery. That's respiratory motion. It is a so important factor during providing of radiotherapy of lung cancer. And finally, I can say that surgery is the mainstay for resectable and operable non-small cell lung cancer. Radiation plays a role in the definitive and adjuvant management for treatment of non-small cell lung cancer. Chemotherapy is an important adjuvant treatment modality often used with radiation, and radiation along with chemotherapy are useful for palliation. Okay, and in first stage, surgery, the mainstay, and single beam radiotherapy. In second stage, surgery is the mainstay and single beam radiotherapy. Third stage, surgery with radiotherapy, chemotherapy with radiotherapy. And finally, in fourth stage, palliative radiotherapy and prophylactic cranial irradiation. For treatment of non-small lung cancer, brachytherapy is used in form as endobronchial brachytherapy and interstitial brachytherapy. Brachytherapy refers to the placement of radioactive source within or in close proximity to a malignancy in order to provide high dose of radiation. Endobronchial brachytherapy is largely a palliative therapy for the treatment of local advanced non-small cell lung cancer involving the airway. Interstitial brachytherapy is the placement of the isotope into a tumor bed where no lumen exists has been described, but is utilized infrequently in clinical practice. In this table you can see radiation dose for treatment of lung cancer depending on treatment type such as radical, palliative, or in pre-operative phase, post-operative phase. You can see different amounts of total dose of radiation, fraction size, and treatment duration. Okay. In this picture, you can see PET scan image of lung cancer before and after providing of chemoradiotherapy, and you can see full destruction of tumor area after 14 months after radiation. Okay, in this picture also you can see PET scan image after 5 months of providing of radiotherapy. And finally, I can say that radiotherapy plays an important role in the management of lung cancer, and the long course of conventional radiotherapy, usually from 5 to 7 weeks, can be used with surgery and chemotherapy as curative treatment of local advanced cancers. Stereotactic body radiation therapy is a promising new treatment for stage first non-small cell lung cancer, and short course from 1 to weeks of palliative radiotherapy can be useful for symptom control in patients with more advanced disease. Okay. Now I will explain larynx cancer radiotherapy. Larynx cancer is a rare cancer in which malignant cells grow in the larynx or voice box. Smoking tobacco and drinking alcohol are the main risk factors of larynx cancer. Other risk factors include age. For example, larynx cancer occurs most often in people over the age of 55. Gender. Men are more likely to develop cancer of the larynx. A personal history of head and neck cancer. Nearly 1 in 4 people who have had head and neck cancer will get it again. And occupation. Workers who are exposed to sulfuric acid mist, wood dust, nickel and other gases have a greater risk of larynx cancer. Okay. In this picture you can see classification of larynx cancer depending on area. We have 3 main types of larynx cancer: glottic tumor, tumor in the glottis; subglottic tumor, tumor in the subglottic area; and supraglottic tumor, tumor in the supraglottic area. Most laryngeal cancers occur in the squamous cells, which line the inside of the larynx, and about 60% of larynx cancer start in the glottis. Some of the following may be signs of larynx cancer. They are a sore throat or cough that does not go away, a change of voice such as hoarseness that does not get better after 2 weeks, any pain or other trouble when during swallowing, ear pain, a lump in the neck or throat, and dysphonia, that is problems producing voice sounds. Okay, in this table you can see TNM classification of larynx cancer. In this picture also you can see the classifications that's depending on size. Larynx cancer also has 4 stages. T1, tumor limited to one subside of supraglottis with normal vocal cord morbidity, as you can see here. T2, tumor invades mucus of more than one adjacent subside of supraglottis or glottis or region outside the supraglottis or glottis or region outside the supraglottis without fixation of the larynx. T3, tumor limited to larynx with vocal cord fixation and or invades any of the following postcricoid area. And finally, T4, moderately advanced local disease, tumor invades through the thyroid cartilage and invades tissue beyond the larynx. For treatment of larynx cancer is used surgery. Surgical management is laser surgery for vocal cord tumors, partial laryngectomy, removing of half or more of the larynx, such as supraglottic laryngectomy and supracricoid partial laryngectomy. Okay. Total laryngectomy for glottic tumors, cervical lymph node dissection and such as radial neck dissection and modified radial neck dissection. Okay, For treatment of larynx and hypopharyngeal cancers, radiotherapy may be used in several ways. As the main, as primary treatment for some early stage larynx and hypopharyngeal cancers, if the cancer is small, it can often be destroyed by radiation and surgery is not needed. This can help to preserve better voice quality. That's in early stage of larynx cancer. We can use primary radiotherapy, radical radiotherapy, to treat patients who are too sick to have surgery. Radiotherapy also is used after surgery to try to kill any small areas of cancer that may remain and help lower the chance the cancer will come back. This method we call adjuvant treatment. To treat cancer that comes back after treatment. And finally, to ease signs of advanced laryngeal and hypopharyngeal cancer such as pain, bleeding, and other problems caused when cancer spreads to the bones. And this method we name palliative radiotherapy. Okay, radiotherapy for in this picture you can also see a computer tomography image of subglottic laryngeal cancer. Radiotherapy for laryngeal and hypopharyngeal cancer is usually given in daily fractions, 5 days per week for about 7 weeks as classic dose fractionation. Other schedules for radiotherapy may be used to treat laryngeal cancer. For instance, in hyperfractionation radiation therapy, you know that a slightly higher daily radiation dose is split into 2 smaller doses and the patient gets 2 doses per day instead of 1. Okay. In this picture you can see types of radiotherapy of larynx cancer. First of all, I will say that among of these methods, methods of external beam radiotherapy is so important, and some types of external beam radiotherapy for treatment of laryngeal cancer include standard external beam radiotherapy aims radiation to tumor from one direction. This is much like getting an X-ray, only it lasts longer. 3-dimensional conformal radiotherapy. This method uses a computer to aim radiation to tumor from several directions. This can decrease the dose of radiation to nearby healthy tissue and help lessen side effects. Intensity modulated radiotherapy. This method uses a computer to control both the direction and strength of radiation reaching to tumor. This can also decrease the dose of radiation to nearby healthy tissue and help lessen side effects. But other type of radiotherapy is internal beam radiotherapy and brachytherapy, and this method is not used very often for laryngeal cancer. Okay. Esophagus cancer radiotherapy. First of all, I will say that esophagus cancer is cancer arising from the esophagus, and the signs often include difficulty in swallowing and weight loss. Other signs are pain when swallowing, a hoarse voice, enlarged lymph nodes, dry cough, and other. In this picture you can see clinical signs of esophagus cancer. Also, okay, in this table you can see T and M staging of esophagus cancer. The early stage esophagus cancer are called stage 0. It then ranges from stage 1st through 4. As a rule, the lower the number, the less of cancer has spread. A higher number, such as stage 4, means cancer has spread more, and within a stage, an early later means a lower stage. Although each person's cancer experience is unique, cancers with similar stage tend to have a similar outlook and are often treated in much the same way. For diagnosis of esophagus cancer are used different types of diagnostic method. First of all, endoscopy. Endoscopic transesophageal endoscopic ultrasound. This method shows the normal esophagus wall with 5 alternating hyper and hypoechoic layers. Okay. The hyperechoic layer between the hypoechoic inner and outer muscularis propria is the inner muscular connective tissue layer and is sometimes seen prominently. And for treatment of esophagus cancer also we can use from fluoroscopy with barium swallowing, and you can see a filling defect if patient has esophagus cancer with incorrectly borders and unshaped form, and computer tomography. In this method, in axial contrast enhanced computer tomographic image at the level of the right pulmonary artery shows a suspicious small nodular lesion in the mid esophagus, as you can see here. A finding that is not easy to detect without endoscopy. The lesion was later confirmed to be squamous cell esophagus carcinoma. Okay. Treatment of esophagus carcinoma, treatment options are surgery, radiotherapy, and chemotherapy. Okay. When is radiation therapy used for esophagus cancer? Radiation therapy may be used as part of the main treatment of esophagus cancer in some patients, typically along with chemotherapy. And we name it chemoradiotherapy. This is often used for people who can't have surgery due to poor health, or for people who don't want surgery. Before of surgery and along with chemo when possible, to try to shrink the cancer and make it easier to remove. This is called neoadjuvant treatment. After surgery and along with chemo when possible, to try to kill any cancer cells that may have been left behind but are too small to see. This is known as adjuvant therapy. And to ease the signs of advanced esophagus cancer, such as pain, bleeding, or trouble swallowing, this is called palliative therapy. That is, depending on stage of esophagus cancer, we can use them with chemotherapy, with surgery, in neoadjuvant, adjuvant, and palliative modes. Okay. External beam radiotherapy, you know that is one type of radiotherapy used most often for people with esophagus cancer. The radiation is focused on the cancer from a machine outside the body. It's much like getting an X-ray, but the radiation is more intense. How often and how long the radiation treatments are delivered depends on the region the radiation is being given and other factors. It can last anywhere from a few days to weeks. Internal beam radiotherapy or brachytherapy is a type of radiation where a doctor pass an endoscope down the throat to place radioactive material very close to the cancer. The radiation travels only a short distance, so it reaches the tumor but has little effect on nearby normal tissues. This usually means few different side effects than with external beam radiation. The radioactive source is removed a short time later. Brachytherapy is not used often to treat esophagus cancer, but may be helpful with more advanced esophagus cancer to shrink tumors so a patient can swallow more easily. This technique can be used to treat a very large area, so it is better used as a way to relieve signs. Brachytherapy can be given two ways. For high-dose radiobrachytherapy, in this type, the doctor leaves the radioactive material near the tumor for a few minutes at a time, which may require several treatments. In low-dose rate brachytherapy, a lower dose of radiation is put near the tumor for longer periods, from 1 to 2 days at a time. The patient needs to stay in the hospital during this treatment, but it can usually to be completed is only 1 or 2 sessions. And other types of radiation, such as intensity modulated radiotherapy, as well as proton therapy, are being studied to treat esophagus cancer. Okay, in this picture you can see a computer tomographic image of esophagus cancer. This method showing complete disappearance, as you can see here, complete disappearance of a large squamous esophagus cancer after chemoradiotherapy, before and after of providing chemoradiotherapy. Okay, in this picture you can see PET scan before and 2 months after completing radiation. The PET scan may continue to show improvement for several months, as you can see here. Okay, CAT scan is obtained at the time of simulation. You know that it is so important stage before of providing radiotherapy. That's CAT scan images are then imported into the treatment planning computer, and so important is for providing of radiotherapy, so important is identifying the gross tumor volume, clinical tumor volume, planning tumor volume, and identify the normal structures that may be affected. That's all these areas we can correctly estimate with help computer tomography. Okay, in this picture you can see radiation dose for treatment of esophagus cancer in pre-operative phase, in post-operative and definitive types of radiotherapy. You can see amounts of radiotherapy and dose fractionation. Okay. Now I'm explaining breast cancer radiotherapy. Breast cancer is a second leading cause of cancer death among women. The development of breast cancer is a multi-step process involving multiple cell types, and its prevention remains challenging in the world. Early diagnosis of breast cancer is one of the best approaches to prevent this disease. In some developed countries, the 5-year relative survival rate of breast cancer patients is above 19% due to early prevention. In the recent decade, great progress has been made in the understanding of breast cancer as well as in the development of preventative methods. Okay. Schematic diagram of risk factors and preventions of breast cancer. You can see in this picture age, family history, reproductive factors, estrogen and lifestyle are 5 important risk factors of breast cancer represented in the pyramid chart, as you can see here. Screening methods such as mammography, ultrasound, magnetic resonance tomography. Chemoprevention and biological prevention are currently being used to prevent breast cancer. Okay, in this picture you can see types of breast cancer: ductal carcinoma in situ, labular carcinoma, invasive ductal carcinoma, invasive labular carcinoma, male breast cancer also, and recurrent and metastatic cancer. Okay. The signs of breast cancer, signs or symptoms of breast cancer are different. Rapid change in the appearance of one breast with visible enlargement of one breast, discoloration with red, purple, pink or braided appearance, and warmth of the affected breast suggest inflammatory breast cancer. In inflammatory breast cancer, cancer cells invade local lymph ducts, impeding drainage and causing edema, swelling of breast. Okay. In this picture you can see indications for providing of radiotherapy in breast cancer. These indications are, for example, tumor size is more than 5 centimeter, node positive, positive or close margins, and can be considered in high risk cases. Okay. Technology of for radiotherapy for breast cancer, in these techniques, technique for providing of radiotherapy breast cancer are position techniques, positioning techniques, immobilization, simulation, target volume, treatment planning, dose and fractionation, and setup verification and treatment delivery. Thus, these all are stages of radiotherapy during for providing of breast cancer radiotherapy. In first step, patient positioning and immobilization, our main aim is accurate delivery of a prescribed radiation dose and sparing surrounding critical tissues. Primary goals are reproducibility of position, reduce positioning errors, and can reduce time for daily setup. Okay. Patient position during therapy. Patient is in supine or prone position, arms abducted and externally rotated to 19 or 120 degree. In prone position is suitable for pendulous breast, where breast only radiotherapy is required. Results in significantly better coverage of the breast and significant reduction of dose to the ipsilateral lung and heart. Decreases the skin toxicity due to loss of skin folding, and prone position has different limitations. Okay, in this picture you can see patient position during providing of radiotherapy. Okay, in this picture you can see providing of radiotherapy for breast cancer. Okay. For treatment of breast cancer, brachytherapy modes are so important. Interstitial brachytherapy. In these modes, a number of needles or tubes are placed across the tumor bed, usually in one or two planes, usually under general anesthetic, as using a template or freehand. Needles are placed parallel from each other. In most cases inserted in mediolateral direction. In very medially or laterally located tumors, needles can be inserted in craniocaudal direction also. The treatment volume is generally the tumor cavity plus a 1 to 2 centimeter margin, and the dose can be delivered using a local dose of radiation, high dose of radiation brachytherapy, typically over 4 to 5 days. In this picture, you can see a dose of radiation for providing radiotherapy of breast cancer, and whole breast radiotherapy, chest wall irradiation, conventional dose is 510 gray in 25 daily fractions given in 5 weeks. In hyperfractionation dose schedule, 14 gray in 510 daily fractions of 2.6 given in 3 weeks. Breast boost irradiation to tumor bed and lymph node irradiation in different radiation dose fractionation, as you can see here. Okay, in this picture you can see types of radiation of breast cancer: external beam radiotherapy with help high intensity X-ray beam. We can provide them brachytherapy or internal radiation therapy, radiation delivered through catheters in the breast, and proton beam therapy. Proton beams only to tumor tissue. Okay. In this picture also you can see providing of radiotherapy for treatment of breast cancer. Cervical cancer radiotherapy. Cervical cancer is a type of cancer that occurs in the cells of the cervix, the lower part of the uterus that connects to the vagina, and various strains of the human papillomavirus, sexually transmitted infection, play a role in causing most several cervical cancer. Okay. In this picture you can see staging of cervical cancer. Early stage cervical cancer generally produces no signs or symptoms. Signs and symptoms of more advanced cervical cancer include vaginal bleeding after intercourse, between periods or after menopause, a watery bloody vaginal discharge that may be heavy and have a full odor, pelvic pain or pain during intercourse. Okay. In this picture you can see TNM staging of cervical cancer, and radiotherapy for treatment of cervical cancer. That's depending on the stage of the cervical cancer, radiotherapy may be used as part of the main treatment. For some stages of cervical cancer, the preferred treatment is radiation alone or surgery followed by radiation. For other stages, radiation and chemo given together, called concurrent chemoradiation, is a preferred treatment as the chemo helps the radiation work better. To treat cervical cancer that has spread or that has come back after treatment, radiation therapy may be used to treat cervical cancers that have spread to other organs and tissues also. The types of radiotherapy most often used to treat cervical cancer are external beam radiation and brachytherapy. When external beam radiation is used as the main treatment for cervical cancer, it is usually combined with chemotherapy. Often, a low dose of the chemo drug called usually cisplatin is used. Other chemo drugs can be used as well. The radiation treatments are given 5 days a week for about 5 weeks. That's 5 days per week, about 5 weeks. The chemotherapy is given at scheduled times during the radiation. The schedule is determined by which drug is used. If the cancer has not spread to distant areas, brachytherapy which is brachytherapy, which is described below, may also be given after the concurrent chemoradiation is complete. Okay, but brachytherapy or internal beam radiotherapy paths a source of radiation in or near the cancer. This type of radiation only travels a short distance. The type of brachytherapy used most often to treat cervical cancer is known as intracavitae brachytherapy. The radiation source is placed in a device in the vagina and sometimes in the cervix. Brachytherapy is mainly used in addition to external beam radiotherapy as a part of the main treatment for cervical cancer. Rarely, it may be used alone in very specific cases of early stage cervical cancers. There are two types of brachytherapy. Low dose rate brachytherapy is completed over a few days. During this time, the patient stays in bed in a private room in the hospital with instruments holding the radioactive material in place. While the radiation therapy is being given, the hospital staff will care for patient, but will also take precautions to avoid being exposed to radiation themselves, and high dose rate brachytherapy is done as an outpatient of several treatments. For each high dose treatment, the radioactive material is inserted for a few minutes and then removed. The advantage of high dose radiotherapy treatment is that patients don't have to stay in the hospital or stay still for a long period of time. Now I will explain skin cancer radiotherapy. Skin cancer, the abnormal growth of skin cells, most often develops on skin exposed to the sun. But this common form of cancer can also occur on areas of skin not ordinarily exposed to sunlight. There are three major types of skin cancer: basal cell carcinoma, squamous cell carcinoma, and melanoma. Basal cell carcinoma usually occurs in sun-exposed areas of the body, such as neck or face. Basal cell carcinoma may appear as pearly or waxy bump, a flat flesh-colored or brown scar-like lesion, a bleeding or scabbing so that heals and returns. Melanoma can develop anywhere on the body, in otherwise normal skin or in an existing mole that becomes cancerous. Melanoma most often appears on the face or the trunk of affected men. In women, this type of cancer most often develops on the lower legs. In both men and women, melanoma can occur on skin that has not been exposed to the sun. Melanoma can affect people of any skin tone. In people with darker skin tones, melanoma tends to occur on the palms or soles or under the fingernails or toenails. Melanoma signs include a large brownish spot with darker speckles, a mole that changes in color, size or feel or that bleeds, a small lesion with an irregular border and portions that appear red, pink, white, blue or blue-black, a painful lesion that itches or burns, and dark lesions on palms, soles, fingertips or toes, or on mucous membranes lining in mouth, nose, vagina or anus. Okay. In this picture you can see new staging system of skin cancer depending on size of them. Okay, for treatment, among of different treatment modalities of skin cancer, radiotherapy plays large part. Radiotherapy, the main principles of radiotherapy are: cure rates after surgery and radiotherapy are similar, and choice depends on age, function, cosmesis, primary site, cost, medical condition, treatment availability, and wish of the patient. Indications for radiotherapy of skin cancers are: large lesions for which surgery would produce unacceptable functional or cosmetic results and or involving bone or cartilage, lesions involving fine facial features, lesions with multiple recurrences post-surgical excisions, positive margins, poor surgical risk, multiple lesions, lesions with metastasis to lymph nodes, surgeon preference, and patient preference. Okay, indications to consider radiotherapy of skin cancer are: fixation to underlying structures, for example, cartilage or bone, perineural involvement, poorly differentiated subtypes, recurrent disease, infiltrative growth patterns, and rapid growth. Sometimes radiotherapy must provide in patients with skin cancer in post-operative periods. It's radiotherapy after surgery. Indications are: close or positive margins, perineural invasion, particularly if more than unifocal involvement and nerves more than 0.5 mm, invasion for cartilage or bone, positive regional nodes. Basic principles of radiotherapy for skin cancer are: first, types of radiation, second, types of delivery systems, after that, treatment planning, physics and radiobiological aspects of radiation, indications, which patients to use traditional or new, and clinical data as related to traditional and new results of treatment and complications. Okay, but what is traditional and what is new? Traditional methods are teletherapy with orthovoltage electrons, photons, interstitial brachytherapy, and treatment planning with conventional X-ray and simulation techniques. New methods are treatment with remote loading applicators and molds, electronic brachytherapy, treatment planning with PET scan, magnetic resonance tomography and fusion techniques, and intensity modulated radiotherapy. Also, new methods are electronic brachytherapy and given utilizing spatial applicators with limited size and depth of penetration. Okay, current radiation treatment options for cutaneous malignancies are Green's rays, superficial therapy and orthovoltage, electron beam radiotherapy, proton therapy, and brachytherapy with surface applicators, surface molds, and interstitial therapy. Characteristic of different types of radiotherapy for skin cancer. Low energy X-rays, main properties of them is high skin dose and high bone absorption. High energy X-rays with lower skin dose, less bone absorption, and higher energy, less skin dose. Electrons with higher skin dose, the higher the energy, the more skin dose, and lower beam radiation. And protons, higher radiation with steep fall off and with very limited use in special circumstances. Types of delivery systems for radiotherapy of skin cancers are teletherapy in orthovoltage megavoltage as a linear accelerator, and radioactive source, usually is used cobalt unit. Brachytherapy as in interstitial mode. Remote afterloading systems utilizing applicators and surface molds radioactive source, and generated low energy X-rays. Okay. Types of delivery of radiation for treatment skin cancer. We divide in two parts, traditional methods and modern methods. Traditional methods are teletherapy, orthovoltage X-rays, electron beam, megavoltage X-rays, proton beam, and interstitial implants. But modern methods are surface applicators and molds, radioactive isotope, and generated low energy X-rays with miniature X-ray tubes. In this picture you can see linear accelerator. You know that linear accelerator produce high energy X-rays and electrons, usually single or dual energy X-rays, and require massive shielding, and with help these devices very small to very large field size may be radiated. In this picture you can see cobalt-60 machine for providing of external beam radiotherapy of skin cancer. Okay, and one of modern types of radiotherapy for treatment of skin cancer is electronic brachytherapy. Electronic brachytherapy is a method of radiation therapy using an electrically generated source of ionizing radiation made with a miniature X-ray tube to deliver radiation dose a distance of up to a few centimeters by intracubital, intraluminal or interstitial application, or by applications with the source in contact with the body surface or very close to the body surface. Şimdi bir daha bakın bu üçü neçə dəqiqə oldu birlikdə. And finally brain cancer radiotherapy. Brain cancer can arise from many different types of brain cells, primary brain cancer, or occur when cancer cells from other parts of the body spread to the brain. Brain cancer signs vary but often include weakness, difficulty walking, and dizziness, headaches. Other common brain cancer signs are vomiting, blurry vision, a change in a person's alertness, mental capacity, and other. In this picture you can see grading of brain tumors. Grade, you know that grade means how different the tumor cells look from normal cells when the pathologist examines them under a microscope. And in grade 4 the cells look nearly like normal brain cells and they grow slowly. Grade 2, compared with cells in a grade 1 tumor, these cells look less like normal cells. Grade 3, cells in the tumor look very different from normal cells. The abnormal cells are actively growing. And finally, grade 4, the tumor has cells that look the most abnormal and tend to grow quickly. Okay. A variety of treatments are used to treat brain tumors. The type of treatment recommended depends on the size and type of tumor, its growth rate, brain location, and the general health of the patient. Treatment options include surgery, radiotherapy, chemotherapy, target biological agents, and combination of these. Surgical resection is generally the first treatment recommendation to reduce pressure in the brain rapidly. And in the past 2 decades, researchers have developed new techniques of delivering radiation that targets the brain tumor while protecting nearby healthy tissues. It's so important in radiotherapy. These treatments include brachytherapy, intensity modulated radiotherapy, and radiosurgery. Radiation therapy may be advised for tumors that are sensitive to this treatment. Conventional radiotherapy uses external beam of X-rays, gamma rays, or photons aimed at the tumor to kill cancerous cells and shrink brain tumors. The therapy is usually given over a period of several weeks, while brain radiotherapy is an option in the case of multiple tumors or tumors that can't be easily targeted with focal treatment. Surgery, also called surgical resection, is often indicated for primary brain tumors, and during surgery, tumor tissue removes some or the entire tumor without causing severe damage to surrounding tissues. Surgery may also be used to reduce pressure within the skull and to relieve signs of cancer. Chemotherapy or anti-cancer medications may be recommended also for brain cancer. Chemotherapy, along with radiation, has become the standard of care for primary malignant brain tumors. The use of these drugs or chemicals to slow down or kill rapidly dividing cells can be used before, during, or after surgery and or radiotherapy to help destroy tumor cells and to prevent them from returning. Chemotherapy drugs may be taken by pill or by injection and are often used in combination with radiotherapy. Drugs called radiosensitizers, which are believed to make radiotherapy more effective, may also be prescribed. Types of radiotherapy for treatment brain cancer include intensity modulated radiotherapy, an advanced mode of high precision radiotherapy that utilizes computer controlled X-ray accelerators to deliver precise radiation dose to a malignant tumor or specific areas within the tumor. The radiation dose is designed to conform to the three-dimensional shape of the tumor by modulating or controlling the intensity of the radiation beam to focus a high radiation dose to the tumor while minimizing radiation exposure to healthy cells. Stereotactic radiosurgery, a highly precise form of radiation therapy that directs narrow beams of radiation to the tumor from different angles. For these procedures, the patient may wear a rigid head frame. Stereotactic radiotherapy is similar physically to radiosurgery but involves fractionation. This modality would be recommended for tumors within or close to critical structures in the brain that can't tolerate a large single dose of radiation, or for large tumors. Three-dimensional conformal radiotherapy, a conventional form of radiation treatment delivery that uses a specific arrangement of X-ray beams designed to conform to shape of the tumor to maximize tumor dose and minimize normal surrounding tissue dose. This form of treatment is tailored to the patient's specific anatomy and tumor location. CT and magnetic resonance imaging scan is often required for treatment planning. And brachytherapy, as a temporary replacement of radioactive cells within the body, usually employed to give an extra dose or boost of radiation to the area of the excision site or to any residual tumor. Okay, that is all. Today we have discussed radiotherapeutic methods of widespread malignant tumors. And we have identified that in all cases, choosing of treatment depends on stage of tumor, and to remember that optimal treatment of tumors depends on diagnosing them early. Thank you for your attention.